I'm Dave Kuter. I'm a physician at the Mass General Hospital in Boston. I'm a full-time hematologist. I've been doing hematology for over 40 years and have an interest in many diseases in thrombocytopenia and in hematology. I have been in the past chief of hematology at MGH and run a large clinical service doing basic science research and clinical trials. ITP is an interesting disease. It's probably not as rare as people think it is. It's basically a disorder of a low platelet count. And the way to think about ITP is patients present sometimes with bleeding and low platelet count, but many patients come to a doctor for a routine examination and are found to have a low platelet count. Platelet counts below 10,000 are associated with bleeding. A normal platelet counts over 150,000. And we define ITP as a platelet count under 100,000 with no other clear cause for it. Again, there are many things from leukemia to cancer and chemotherapy that can lower your platelet count, but in general, this is an autoimmune disease. And the way to think about ITP is antibodies are formed. They attack the platelets in the circulation and reduce the platelet count, but then they also attack the bone marrow and prevent the bone marrow from compensating by making less platelets. So we have a problem of increased platelet destruction, but also a problem of inappropriate low platelet production. And these patients in general will have a platelet count that's significant. And we tend to treat patients when the platelet counts are below 30,000, especially when bleeding occurs. If you walk into our clinic and have a platelet count of, say, 10,000, have bleeding manifestations such as blood blisters in your mouth or things called petechia or bruises, we will in general give you corticosteroids as initial therapy. In prior decades, that was continued for months or even years, giving us large steroid side effects. But in general, we use prednisone or things like that, or dexamethasone to raise the platelet count transiently, then introduce other therapies. So the current algorithm for ITP therapy is if you need to be treated, corticosteroids are given. If you're severely bleeding, IVIG is given for 1 or 2 doses. That in general raises the platelet count in the vast majority of IT patients within about 2 to 5 days. In a new patient, they're often discharged from the hospital. And then we have a problem. The problem is the platelet count's now elevated. They have a treatment effect of steroids, but we don't want to keep them on steroids. So usually by week 6 to 8, we wean patients off steroids, and 80% will then relapse with a decline in platelet count. And this brings in other therapies we commonly use, which are things like rituximab, the thrombopoietin receptor agonist, and fostamatinib, which are drugs that in general either decrease platelet destruction or, like the DPhil receptor agonist, will increase platelet production. Again, these agents have about, in total, maybe about an 85% response rate. But there's then the tip of the iceberg, which is 15% of patients who don't respond to these what are called second-line therapies, and one then uses combination modalities. It is a rare patient these days that requires splenectomy, and probably a main message to everyone who sees these patients is we rarely use splenectomy these days because it's usually not necessary and has complications. But in general, medical therapy works for the vast majority of patients, but there's still a tip of the iceberg where there's an unmet medical need. And finally, some therapies, such as the thrombopoietin receptor agonist, need to be continued for a long time. In some patients, maybe forever, but many patients have a spontaneous remission. And the majority of patients, after 1 or 2 years after the presentation, will have some kind of alleviation of their disease, platelet count that's adequate over 30,000, and therapies discontinued. I think right now it's important to distinguish targets for therapy in ITP. The initial disease is made by antibodies, and we usually think that occurs from lymphocytes and other cells that will make antibodies that cause the ITP. With more durable disease, meaning it's been present a longer time, the lymphocyte then becomes what's called a plasma cell. And the plasma cells also make antibodies, probably more efficiently than lymphocytes. And what happens is that in patients with disease that has been around for a while, the plasma cell tends to take over from the lymphocytes making antibodies. So things that are targeted lymphocytes, such as rituximab, oftentimes fail. So mezagitamab is a very interesting drug. It joins a class of medications called anti-CD38 molecules. CD38 is a primitive substance on almost all body cells. In the sea urchin, for example, the CD38 substance serves as a calcium channel. But what's happened over millennia of evolution is this very interesting archaic molecule on the surface of cells has been appropriated by the immune system to be a target for immune interaction. So basically, most immune cells, plasma cells, things called NK cells, and also some lymphocytes have the CD38 antigen on their surface. And mezagitamab is an anti-CD38 molecule which binds to this surface antigen and causes these cells to die. This therapy in the form of a different drug called daratumumab has been highly effective in destroying plasma cells in the disease multiple myeloma. And mezagitamab is now being used like many other therapies in ITP. We steal from the oncology team and develop drugs that we use with similar mechanism of action, but to treat autoimmune diseases like ITP. So mezagitamab is a monoclonal antibody given subcutaneously. It binds to CD38 on NK cells, which is a type of lymphocyte, and also on plasma cells, and causes those cells to die off and not do their function. The clinical trial we did was an exploratory trial, and at the end of the day, we have a total of 41 patients. In the first part of the study, we randomized patients 1:1:1 to placebo, and then 100 milligrams, and then 300 milligrams of mezagitamab. They got weekly injections of mezagitamab, and then this was done for 8 weeks. Once the 8 weeks was finished, which is the treatment period, patients were observed for another 8 weeks to assess their response. So in general, we're talking about the data from a 16-week study, 8 weeks of therapy, and then 8 weeks of subsequent follow-up to assess their response. That study then was, when it was fully enrolled and analyzed, the sponsors and the investigators thought it would be nice to go to a higher dose of 600 milligrams, and a part B of the study was done where the randomization was placebo 1:2 with the active drug 600 milligrams of mezagitamab, also given for 8 weeks, and then a follow-up period with no therapy for another 8 weeks. So basically, we have 2 trials sequentially exploring different doses. Bottom line is weekly therapy for 8 weeks of subcutaneous injection, followed by 8 weeks of follow-up to assess response. And the responses I think about are platelet responses in terms of platelet count rises. But again, this is a phase 2 study where the primary endpoint was adverse events. The secondary endpoints were platelet count responses of different types. And then there are a number of what are called exploratory endpoints to assess other innovative things we think might be interesting in ITP. But the main focus of the study, could we dose escalate in this trial and assess adverse events? And second of all, was there a clinically relevant platelet response? And there are several different platelet count iterations we've used in this study. In the study, we presented data that showed that the adverse event rate, and particularly infections, which is the main concern of any immune modulatory technique, were the same in the placebo group versus those on active therapies. So in general, the major concern we have about anything that plays around with your immune system is the infection rate increased. There are other side effects such as infusion reactions, adverse events like cough and cold, and the typical things we look at that are what I consider minor side effects were certainly no greater in the treatment arm than in the placebo arm. There were a few patients who, for a wide variety of reasons, discontinued therapy with mezagitamab. Those were pretty much not related to toxicity of the medications in most situations. Some patients had a concurrent other medical problems that caused them to discontinue study. But the vast majority of patients came on study and did well. And it's probably important to comment upon who are the patients we studied, because I've already told you that many patients with ITP do fine on their current therapies. The patients that are currently enrolled in many ITP studies, and this is an example, have had ITP for many years and have failed multiple therapies. So we're looking at the tip of the iceberg of those who have not responded well to standard therapy. So on average, the patients who are on placebo arm and those on the mezagitamab arm had disease for on average about 10 to 11 years. They'd failed on average 3 to 4 therapies previously, and the baseline platelet counts were between 15 and 20,000 in the 2 arms. So this is I hate to use the word worst of the worst, but these are the patients with the most severe ITP, which makes the results that we showed at the meeting all the more striking. The take-home message was that mezagitamab was a safe drug in terms of side effects that we commonly worried about. No increased rate of infection, no increased rate of thrombosis. But the major thing was the platelet count rise was quite striking. First of all, the platelet count rose sometimes within 2 days. So the platelet count rise we showed in one of our presentation happened very fast within a week. And I'll come back to that particular point in a second because it brings up an interesting aspect of the mechanism of action of this drug. The second thing I'd say is the response rates vis-a-vis the platelet count rise. And for example, if you look at the number of patients whose platelet counts would rise by, say, 20,000 above baseline obviously being below 30,000 as an entry prior to the study, patients had response rates that were as high as 80% or higher in terms of having a platelet count rise on 2 occasions over this target range. And this was a dose-dependent effect, meaning the patients who had the 100 milligram doses had a nice rise. Those at the 300 milligrams had a higher rise, and those had, with the highest dose of 600 milligrams, had an even higher platelet count rise. And furthermore, the number of weeks during the 16-week study that the platelet count was in target range, again, rose in a dose-dependent fashion, with 10 of the 16 weeks on average, in those who got the highest dose of 600 milligrams, having a platelet count that was in a significant rise. But I think right now, this is the net result is low adverse events, if any major adverse events, significant platelet count rises that are fast, and thirdly, over the 16 weeks, the response was durable. Which brings me up to the last interesting point about this study, which is that it demonstrated maybe a novel mechanism of ITP. We might have learned a bit about ITP in that the response rate happened very fast. And if you think of the plasma cell making antibody, it will take weeks or longer for the plasma cell to die away like it does in myeloma, and the IgG level to drop. IgG levels in these patients did drop by 40-some% with time, but the drop occurred later in the course of the disease, and the rise in platelet count happened very early on, which brings to our attention in terms of the pathophysiology of ITP that we may be killing off the NK cells, and the NK cells may be the main indicator of immediate response in ITP, which is a target of mezagitamab. So it brings to our discussion a somewhat theoretical context that maybe this new drug has additional benefits in ITP that we didn't quite appreciate. Other than dropping IgG, it may affect NK cells, and NK cells, to our surprise, may be one of the major mechanisms by which platelets are destroyed in ITP. I think we're all interested and excited about the data from the mezagitamab phase 2 study. It shows a high response rate, a fast response rate, and what's considered a durable response rate in 16-week study. We need to study this drug for a longer period of time in a larger randomized placebo-controlled study, which is underway. In addition, it's reasonable to think about using this drug earlier in the disease state to see if we can prevent disease progression. Our current therapies are directed to the tip of the iceberg in terms of patients who become, in quotation marks, refractory. It is a goal of ITP doctors such as myself to try to treat patients earlier on to prevent them from becoming chronic. So at some stage, earlier administration of this drug in ITP needs to be considered. So we need 2 studies, a phase 3 study compared to placebo to assess the durability and nature of response, and also a consideration of studying a drug earlier in the disease process to prevent disease progression and prevent it from becoming chronic. Ultimately, our goals with this drug, like many new drugs, is can we cure ITP? We're not there yet.